Last time, we closed on the complement system. Now, the complement system is going to have three major components. There's going to be the classical pathway, there's going to be the alternative pathway, and there's also the lectin pathway. We're not really going to go into the lectin pathway too much. That's something you're going to be familiar with more so when you guys get into microbiology. But for the sake of this class, we're going to talk more, we're going to focus more on the classical versus alternative pathway. Now, the classical pathway, one of the distinguishing features is that this right here. It's going to require antibodies, 2 antibodies. So you have 2 antibodies that bind. There's going to be a little bit of a change in their configuration. And on those antibodies, there's complementing binding sites. And so you get complement binding to those regions on the antibody, and that's going to activate the complement system. That's going to be activating the classical complement system. And because it's involving antibodies, that's going to be part of the adaptive immune system, aka the specific immune system. We'll talk about it in terms of adaptive immune system. That's when your body adapts to an antigen, it creates antibodies. That's the overall consequence of the adaptive immune system. And so it does require it does require the adaptive component to the immune system. Then the other pathway that we're going to talk about is the alternative pathway. The alternative pathway does not require the presence of antibodies. We're going to talk about that in more details, but one of the major goals of the alternative pathway is going to be opsonization. Now, opsonization, as I mentioned last time, I call that glorified phagocytosis. That's just, it's phagocytosis that's going to be mediated by the presence of the complement proteins. So we're going to talk about that in a little bit here. So this was the review, this is the overview that we talked about already. So you got bacteria on both sides here. So you got the microbe, the classical pathway, you got those 2 antibodies. And then it binds to C1, which is the first complement protein, and then it results in a cascade of downstream effects. And then C3 is going to be resulting in a few different consequences. You're going to have mast cell degranulation, aka histamine release, which is going to allow for vascular permeability, opsonization, as I mentioned, that glorified phagocytosis, and then the MAC, which is the membrane attack complex formation that resolves in lysis of the cell. The alternative pathway, a little bit different. It's going to involve C3, C3b specifically, and then that's going to also result in degranulation, opsonization, and the MAC formation. So let's go into the different types of proteins involved. So complement proteins, there's 9 major complement proteins. One of the common pathways that we're going to talk about is going to involve C3 and C3 convertase. The thing about C3 is that once you get C3 developed, it's a very unstable protein, and so it's going to transform into both C3a and C3b, both of which are going to be doing different things. So we're going to talk about those in greater detail. But here's a summary of the major outcomes. You're going to have histamine release, which increases vascular permeability. You're going to have the MAC, which is the membrane attack complex, that basically compromises the outer membrane of a bacteria, resulting in lysis. And then you also get opsonization, i.e. glorified phagocytosis. Now, the alternate pathway, bless you, that's going to be involving C3b. So C3b is going to bind to the bacteria, and it's going to result in that cascade of other complement proteins being involved. Classical pathway requires those 2 antibodies. And then the lectin pathway is a little bit different. It's going to involve mannose. And mannose, this is carbohydrates. So it's a carbohydrate binding protein. You find mannose on certain microbes at the end of the day. We're not going to talk about the lectin pathway as much for the purpose of this class. So you can feel free to maybe even scratch that off this chart. This chart is awesome. I really like it a lot because it really explains all the different complement proteins that you guys need to know. So let's talk about the classical pathway. The classical pathway, as you notice over there, there's 2 different antibodies attached to the microbe. That's how it starts. It requires 2 antibodies. So it's going to also involve it's going to involve not the innate immune system, but it's going to involve the adaptive immune system, the specific immune system. And then the common pathway is going to be once you get C3 and then C3 convertase, that's going to result in all these things happening downstream. So let's talk about the alternative pathway. As you notice, C3b, that's going to be what begins the alternative pathway. C3b binds to the microbe, and then once that happens, it's going to result in a cascade of C3 convertase, turning C3 into all sorts of different complement proteins. So let's go into what these different proteins do. So let's start over here on the left. You see this leukocyte? It's kind of chilling in the blood vessel. Leukocytes are often going to be found within the blood vessels, right? It's part of your white blood cell count. In order for those leukocytes to actually do something, aka kill a microbe, maybe you have an infection, maybe you got cut, maybe you introduce some bacteria into a flesh wound, you want those leukocytes to be able to leave the circulatory system to go into the interstitial space so they can actually kill the bacteria that's been introduced into the regions outside of the blood vessels. And so this is called diapedesis. So when you see that leukocyte is flowing through the blood vessels, once it gets stimulated by C3a and C5a, that's going to result in diapedesis. Diapedesis is a fancy word for blood cells walking. So in other words, the leukocyte is going to start walking along the inner lumen of the blood vessel until it is allowed to make its way into the interstitial space. So in other words, it's going to go from the bloodstream into the interstitial space. So it can actually address the bacterial infection. So those are going to be C3a and C5a. Those are the two major complement proteins associated with leukocyte diapedesis. Okay? Then the next one over here on this side is going to be opsonization, aka glorified phagocytosis. The major complement protein associated with that is C3b. Okay, so think about up here, you have the alternative pathway. C3b binds the microbe. C3b eventually accumulates around the entire periphery of the microbe, and then that gets recognized by a phagocyte, and then now that microbe gets gobbled up through phagocytosis. So that's going to be C3b. Now the very last step is going to be the big guns. So the membrane attack complex, that's the way that you punch a hole through the bacteria to allow that bacteria to explode through lysis. You're basically compromising the integrity, the structural integrity of the bacteria. And that's going to be C5b. So diapedesis, leukocytes walking, C3a, C5a. Think first letter in the alphabet, A. Think about leukocytes coming to the site. That's one of the most important parts of your defense mechanism, is getting leukocytes to be able to phagocytose foreign invaders. Second thing is phagocytosis. So think C3b. Maybe think it's binding to a bacteria. That's maybe one way for you to think about it. So C3b binds to the outside of the bacteria so it can get recognized and engulfed. And then the final step, C5b, that's going to be basically turning into a membrane attack complex. C5b suddenly begins to allow recruitment of other complement proteins that allow for punching a hole into the bacteria. So to summarize, C3a, C5a are going to be associated with recruiting phagocytes to the site of injury or where there might be a bacterial infection taking place. Opsonization or glorified phagocytosis, C3b, think it's going to be binding to the outside of the bacteria. And then the last step is going to be C5b. Okay? And once C5b gets recruited, you get all these other complement proteins, 6, 7, 8, 9, and all those basically form a giant tunnel through the outer membrane of the cell. It allows that cell now to become lysed. And these are some electron micrograph images of what those membrane attack complexes look like. Those are those like little channels, little holes that they're punching into the outside of the bacteria. Let me see how long this video is. If this video is too long, I'm going to just let you guys watch it on your own time. Oh, it's only 1 minute, but I remember this one. This one's got some crappy animations, but it gives you the overall concept. Sorry, that was so loud. So C3b, it's binding to the outside of the cell. And then it gets gobbled up. And this is where you get the membrane attack complex being produced. Some magnificent CGI. That was hilarious. All right, so in terms of chemotaxis, C5a is going to allow for chemotaxis, movement of the white blood cell along the lumen of the vessel. And then C3b, that's what basically surrounds the bacteria so that it can get phagocytosed by a leukocyte. Cool. Any questions on complement? So if you know C3a, C5a, diapedesis, if you know C3b, opsonization, getting surrounding the bacteria, and if you know C5b as being the last step, which is the membrane attack complex, you should be pretty good on the complement system. Okay? Awesome. So let's talk about inflammation. Now, there's a lot that's involved in inflammation, especially when it comes to cytokines. Cytokines are basically chemicals that are sent out by cells to be able to communicate. It's the way that cells can communicate with each other. They send out cytokines. Cytokines can be involved in all sorts of different types of things, most of which are way beyond the scope of this class. If any of you go into grad school and you learn about immunology in grad school, there's tons of like interferons, interleukins. There's like interleukin 1, 6, 2, interleukin 12, all sorts of different interleukins are all going to be involved in different types of like inflammatory processes, things that you're not responsible for. Just know that cytokines, those are involved in communication between cells. And any of these are going to be associated with the inflammatory process, especially when we talk about inducing apoptosis. Tumor necrosis factor is going to be a pretty important cytokine that's going to be released by cytotoxic T cells, which we're going to talk about in a little bit. In terms of inflammation, the major goals of inflammation are going to be to help fight infections and to aid in tissue repair. Now, one of the hallmarks of inflammation is going to be swelling. That swelling is going to be due to vasodilation. It's going to be due to release of histamine, for instance. It's going to allow for cells to enter into that area so that they can actually, kill the invader, kill the bacteria that's involved in the infection. And then also the removal of debris. Macrophages are very much going to be implicated in that process. And then tissue repair, that's going to be associated with things like fibroblasts, other types of cells that help to allow for wound healing. So these are the major 4 cardinal signs of inflammation. Some people like to talk about loss of function as being one of the cardinal signs of inflammation. That obviously doesn't always happen just because you stub your toe and your toe gets inflamed. You don't just like lose function of your foot or whatever. Loss of function is generally going to be associated with a very severe form of inflammation. But the major ones are going to be redness, heat, swelling, and pain. And in Latin, and actually in some other Latin-based languages like Spanish, Portuguese, a lot of these are going to be very similar. So calor, dolor, rubor, and tumor. And then functiolase, that's the loss of function. But don't worry about loss of function. That's sometimes considered to be one of the fifth signs of inflammation. So when we talk about redness, we use the term erythema. Okay, so when you guys are in the clinic, you refer to anything that's red as being erythema. Okay, swelling, we talk about in terms of edema. That's capillary permeability. Heat is going to be due to basically blood cells entering into that area, and that's what's actually causing the heat. You got a bunch of vascular mobilization, right? You have a bunch of blood entering into that space to aid in the inflammatory process. Now, in terms of pain, that's going to be moderated by a few things. Prostaglandins, we talked about prostaglandins a little bit already. Prostaglandins are going to be involved in pain as well as bradykinin. So those are going to be some inflammatory mediators associated with pain and the inflammatory process. So let's talk about fever. If you ever heard someone say, oh, I have like a low-grade fever, it's like 99 degrees or something, that's not a fever. Fever is only when you get to 100.4 and above. Once it goes 100.4 and above, that's when you actually call it a fever. Also, 38 degrees Celsius would be considered a fever. Now, in terms of what fevers do, fevers are beneficial. It's part of your innate defense. It's part of your innate immunity. When you guys get into microbiology later on, when you start doing culturing of bacteria on plates, or like augers, you know, it could be like a broth or whatever, a lot of times you're incubating the organisms at 37 degrees Celsius. 37 degrees Celsius is right about body temperature. Lots of bacteria enjoy living in body temperature. Especially the pathogenic ones, the ones that cause disease. They like to hang out in our bodies at our body temperature. Once you start cranking the temperature up through fever, that's going to help to like mitigate bacterial growth. Sometimes it can even help to kill bacteria. They don't like to get too hot. There's some that actually do, like extremophiles or thermophiles, those kind of bacteria, they actually do enjoy hotter temperatures. And there's also some bacteria that enjoy lower temperatures. Like, for instance, the bacteria that causes leprosy, Mycobacterium leprae, it likes cooler temperatures, around like 25 degrees Celsius. So generally speaking, like leprosy affects distal appendages like your fingers, cartilage, so ears, nose. But by and large, a lot of the bacteria that cause infection and disease, those are going to enjoy body temperatures. So that's one way that fever can help to kill bacteria and other infectious agents. Fevers are going to be mediated by one of your cytokines, interleukin-1. That's one of the major ones that are involved in fever development. And those are called pyrogens. When you hear pyro, like fire, right? Pyrogens are going to be cytokines that induce fever. Those are going to be involved, those are going to involve macrophages. Macrophages are the ones that actually secrete interleukin-1. And then as a result, you're going to get the release of things like prostaglandins, right? Prostaglandins can cause pain, but they can also result in fever. Now, fevers are good up to a certain point. Once you start getting into like the higher grade fevers, like 105 and beyond, that can really start affecting your brain. Your brain doesn't like to be hot. And so once you start getting to those temperatures, you can start getting into like altered mental status, delirium, and then you can also eventually maybe get into a coma, and obviously you can die as a consequence. So fevers are good up to a certain point. Here's an interesting image that talks about the timeline of different aspects of the inflammatory process. So at the beginning, we talked a little bit about when you get a cut, right? You get vasoconstriction to help prevent loss of blood. So that's going to be one thing that happens when you have an injury, for instance. You get coagulation. We talked about the coagulation cascade as being part of that. Eventually, you get dilation, right? So you get histamine release. So you can increase vascular permeability. So you can increase the cells that go to those areas to fight off infection, as well as to help in like tissue repair. And then all sorts of other stuff happen, like neutrophils will start coming into the area to fight off bacteria. Fibroblasts, that's allowing for actual wound healing and tissue repair. And so it's kind of interesting to see the time frame. So Fibroblasts, that's about 12 hours, 24 hours into the injury. Then you have the process that goes into wound healing that can take up to weeks, if not months, if not years. So let's talk about natural killer cells real briefly. Natural killer cells, they're going to be amongst your lymphocytes. So among your lymphocytes, you're going to have quite a few. You can have T cell lymphocytes, B cell lymphocytes. Amongst lymphocytes, you're also going to have natural killer cells, but they're a little bit different than your other lymphocytes. Natural killer cells are going to be involved in two major, the release of two major components. So they're going to release perforins. So perforin, think of it as just basically perforating the outer layer of a cell. And then granzymes are going to be enzymes that basically induce apoptosis. Apoptosis is a fancy word for controlled cell death. It's how a cell can basically die without resulting in a greater amount of inflammation. The problem with cell death, when it's not under, if it's not through apoptosis, is that you get the release of all sorts of different compounds from within the cell, some of which can result in damage to all the surrounding cells, right? So apoptosis is a way to control that. When you induce apoptosis, mostly through things like, well, granzymes, also tumor necrosis factor can induce apoptosis. The cell starts to compartmentalize all the components. They start forming these blebs. These blebs are these little things that kind of start coming off of the outer layer of the cell. Those blebs get phagocytosed by other cells in the area, and then those components start getting integrated into other cells. So it's a much more controlled process, so it reduces inflammation. But natural killer cells are going to be coming into play when a cell is infected by viruses or if you're dealing with cancer cells. So if a cell is infected at all, it's going to start releasing different types of cytokines to inform natural killer cells to come in there and basically induce apoptosis. Oh yeah, and then after apoptosis takes place, the macrophages can basically come in and gobble everything up. So here's a couple summaries of your non-specific type of defense. So you got phagocytes, you got a bunch of them, neutrophils, macrophages, eosinophils, etc. Physical barriers. We talked about natural killer cells just now. Interferons. Interferons basically interfere with viruses. If you ever see interferons, you're thinking viral infections. Also the complement system that we already discussed. So if this is the complement system, what are these proteins right here? Which one are they? Which are the complement proteins? C3 what? C3b? Good, awesome. So those would be C3b surrounding, that looks like an E. coli maybe. It's a gram-negative rod of some sort. Inflammation, mast cells. Mast cells are going to be very much implicated in the inflammatory process. Mast cells help to release things like histamine. Histamine release is going to increase blood flow to that area because of vasodilation. It's going to actually help for capillary permeability, right? So capillaries become leaky. You get different things going into those interstitial space to be able to actually fight off infections. All sorts of stuff is taking place. And then fever, of course. That's going to be another way for your body to fight off infection. So that is all innate immunity. That's non-specific, okay? Unless it involves antibodies, like in the classical pathway of complement. Everything else that we talked about, that's all just innate. You're just born with that. Now let's get into the specific or adaptive immune system. I'm not going to really use the term specific as much. I'm going to more so refer to it as the adaptive immune system from now on. And that's going to be your third line of defense. That's cell-mediated or humoral immunity. Those are the two major branches of the adaptive immune system. Now, the adaptive immune system, once it gets activated, it can get activated in two different phases. You have the initial onset of an infection, right? And that's going to be a little bit longer for you to mount the reaction against whatever is causing the infection. So oftentimes it takes anywhere between 7 to 10 days for that infection to get addressed. So that's 7 to 10 days to start creating antibodies against the antigen that's causing the infection. So that can take a little bit of time, and once you get the antibodies as well as the memory cells, as a consequence of that primary infection. The second infection is going to be much more rapid, and it's going to be much more aggressive. I'm going to show you a chart of what that looks like a little bit later in this presentation. But for now, let's talk about this chart right here. So this over here is the first primary infection, right? Say, I don't know, you get sick from, it's a good virus. Maybe it's influenza, okay? Maybe it's just influenza A, something like that. So you get exposed to influenza at the onset. It takes about 10 days for your body to develop the immune response to actually fight off the infection, okay? So once you get exposed, the naive B cell becomes activated. Once it gets activated, then it's going to eventually turn into a plasma cell. Okay, so plasma cells are going to be the consequence of differentiation and proliferation of that B cell. So now your plasma cells are what actually secrete immunoglobulins. Immunoglobulins are now going to be secreted to target that specific antigen. So if it's influenza A, I don't know what serotype, there's tons of different serotypes, but it's a specific serotype of influenza, it would be only for that serotype. No other serotypes. That's why when you get a vaccination for flu vaccines, they give you 3 major serotypes, the most common ones that you're going to see during a season. If you get infection from a different serotype, that vaccine is not going to do any good. So when you get influenza vaccination, it's mostly effective because it's going to be targeting the 3 most common serotypes. So let's just focus on just one of those serotypes. Now, if you, after the infection's over, now you're going to have memory cells. You're also going to have IgGs floating around in your body that are going to be able to target that same exact antigen at a future exposure. So once you get exposed the second time, you already have those memory cells that have been developed. You have those memory cells, and you also have the immunoglobulins that directly are associated with those specific antigens. Now, the second response is going to be much more rapid, and it's going to be much more aggressive. So 5 days versus 10 days. So basically, the duration of the response is cut in half, and it's much more aggressive. And IgGs are going to be heavily implicated in this second response as well. So that's going to be kind of the way that your cells develop quote-unquote memory. That's why it's called the adaptive immune system. You're adapting to specific antigens. All right? It can also go wrong. So if you've heard of people that have autoimmune diseases, this is part of the process of autoimmune diseases. Generally speaking, when somebody has an allergy to something, for instance, when I was living in the West Indies, when I was going to med school, we had the world's largest centipede. It was a foot long. It's called Scalopandra gigante. It can sting you from both sides. So if you step in the middle, it can sting you from both ends. It's not the first bite that can kill you. The second bite can kill you. If you get bit by it again in the future, there's been reports of people having a hyper-reactive allergic reaction. So like anaphylaxis as a consequence. Anaphylaxis can be this whole process right here gone kind of haywire, a much more aggressive secondary reaction. So this can actually be a little bit dangerous for the host depending on how sensitive you are to the antigen. So moving on, let's talk about the 2 major branches of the adaptive immune system. You have the humoral immune system, and then you have the cell-mediated immune system. The reason why I put this really cool art over here is because if you study ancient medicine, right, if you read like Hippocrates, or if you read Pliny the Elder, and all those old dudes from like the Greek era 2,000 years ago, they're going to talk about the 4 humors. Back in those days, they used to think diseases were an imbalance of the 4 humors, the 4 of which were phlegm, blood, yellow, and black bile. We think that that medicine obviously doesn't relate to what we do nowadays. However, we still use that term. So humoral, you're thinking fluids. Think about the vitreous humor in your eye. That's the fluid within your eye. So if you think humoral immune system, you're thinking plasma, all right, because plasma is mostly made up of water, also plasma cells, and in plasma you also find immunoglobulins, okay? So that's what we're talking about when we talk about the humoral immune system. So it's going to be antibodies, B cells, plasma cells, okay? Those are the major components of the humoral system. And then cell-mediated immune system is a little bit different. It's going to be mediated by mostly T cells. So T cells, both helper T cells as well as cytotoxic T cells. So we're going to talk about the two different types of T cells. Well, there's 4 different types of T cells, but the 2 major ones that are of concern for this class. And this last point right here, these reactions can be very dangerous. As I mentioned, autoimmune disorders, right? Autoimmune disorders basically arise when a person's immune system is kind of like hyperreactive, or if a person's immune system is bored. If your immune system is bored, oftentimes those cells start getting out of hand. They start attacking yourself. Autoimmune disorders are most common in developed nations such as the United States, other Western countries that have like great infrastructure. Great infrastructure is good, right? Because you're not drinking contaminated water. You're not having to get exposed to nasty bugs and whatnot. But what also happens is that your immune system starts to get bored. In places that have crappy water and not really great infrastructure, places that don't have great access to healthcare as well, they have more parasitic infections. And because of the parasitic infections and other sorts of infections, their immune system is oftentimes very busy. Because of that, in those more underdeveloped nations or developing nations, I don't know what the PC term is for it nowadays, but those areas that don't have great access to healthcare or infrastructure, autoimmune disorders aren't very common there. Autoimmune disorders are more common here in the United States. Celiac disease, rheumatoid arthritis, things like that. Those are all autoimmune disorders. So, anyways, I digress. But so in other words, there's got to be ways for your body to actually control these cells. We're going to talk about some of the controls for T cell development because you don't want to have way too many T cells in your body. Generally speaking, your body actually destroys the majority of T cells that are created. We make way more T cells than we actually need. And so what happens is that we sort of like prune back the number of T cells. Otherwise, those T cells would start to attack healthy cells. So, in terms of the different types of lymphocytes that are circulating, the majority are going to be T cells. 80% of all lymphocytes are going to be circulating T cells. And they're going to be thymus dependent because remember, thymus, that's where T cells migrate to go get matured and to further develop, right, through the release of thymosin and things like that. 15% are going to be B cells, and those are all going to be associated with the bone marrow. So B cell, bone marrow, and then natural killer cells are going to be a very small percentage, so 5% of all of your lymphocytes are going to be natural killer cells. They're very important, but they're not as numerous. So these are all your T cell derivatives. So we talked about cytotoxic T cells. We're going to go into more details about those. We talked a little bit about helper T cells. Suppressor T cells. Those are the ones that are going to be able to help prune back all the T cells that aren't really necessary. So they basically help to kind of tamp down the immune system, make it so it's a little bit more regulated. Okay, so it kind of acts as like checks and balances to make sure that everything is sort of within normal limits. B cells, that's going to be your humoral immune system. When B cells get activated, they get activated and they proliferate, and they eventually turn into these guys, plasma cells. And plasma cells are what secrete immunoglobulins. And then natural killer cells. That's going to be the smallest percentage of all these cells. Those are the ones that are mostly associated with the innate immune system, not so much the adaptive immune system. These guys over here on the left side, all of these cells here, that's all adaptive immune system. So that's adaptive, pardon my handwriting, and this is innate. Okay? So that's for the most part, okay? Moving forward. So we just talked about this a little bit already. When we talk about the adaptive immune system taking about 7 to 10 days, that's when you have the very first exposure. It takes, on average, 10 days for your B cells to proliferate, turn into plasma cells, secrete immunoglobulins, okay? Then those B cells turn into memory B cells so that if you get exposed the second time, you can mount that reaction much quicker. All right, so we just kind of, to reiterate, T cells, thymus, to reiterate, B cells, bone marrow. What's up? Not to my knowledge. Like, you would probably have the same duration. Like, if you got that same serotype of influenza like a third time, it would probably still be similar to that second exposure. That's a great question. Yeah, that's a really good question. I don't think it is faster. I think it's about the same duration of time because those cells go into memory. They kind of go into hibernation. You have those floating like immunoglobulins, the IgGs floating around, and so I think the overall reaction would be the same. Now it's duration dependent. If say you got that infection 10 years down the road, then it would be probably equivalent to getting a first time reaction, right? That's why if you get, for instance, like the tetanus vaccine is good for 10 years. Right? After 10 years, you have to get another one because after 10 years, you basically lose those memory cells and the IgGs are no longer going to be robust enough to actually mount a proper reaction. Same thing with the MMR vaccine. Like when I was doing my clinicals, before I had to go start doing my clinicals, we do titers. You guys ever heard of viral titers? Or immunoglobulin titers? It's different, sorry. So when you get your titers done, you guys are all going to do that once you start getting into clinic. They basically check to see if you have enough titers in terms of immunoglobulins against measles, mumps, rubella. Before I went to go do my clinicals, my rubella titers were low. So I had to get the MMR vaccine again. So yeah, even though you got the vaccine, after a period of time, you might lose those memory cells, you might lose the immunoglobulins, you just have to get it done again. Not the end of the world. In terms of like the tetanus vaccine, there's a couple different types. There's the actual, there's the immunoglobulin that attaches to the toxins. Those don't really last very long, but the actual tetanus vaccine, which I can't remember what it's called off the top of my head, but that's supposed to be good for 10 years. If somebody, like myself, fell off a scooter and got knocked out and woke up in an ambulance, and you didn't know the person's like tetanus vaccine status, you generally would give them another tetanus vaccine. So when I looked at my charts, when I had an accident a couple years ago on a scooter, and it turned into an eggplant, I looked at my charts, it's like, damn, they gave me another tetanus vaccine. Because they didn't know. I couldn't tell them because I was incapacitated. So generally speaking, if you don't know what the status is, you'll give them another vaccine. If they knew what my status was, they would probably just give me the immunoglobulin. So just in case I got tetanus, it would render the toxins neutral. So that is my scooter story. And I will never ride on an electric scooter again because of that, especially here on campus, lest one of you guys should see me fall. That would be extremely embarrassing. Now, for T cells to be activated, they need to be activated by antigen-presenting cells. And this is probably one of the most annoying parts of immunology. We're going to talk about what antigen-presenting cells are. These are all going to be antigen-presenting cells. Macrophages can be antigen-presenting cells. Dendritic cells are going to be antigen-presenting cells. B cells can also be antigen-presenting cells. But the ones that I'm going to focus mostly on are these guys, especially dendritic cells. So we're going to talk about that in a moment. But the whole concept of having to present an antigen to activate a T cell, it's initially annoying to learn, but once you get it, it sort of makes a little bit more sense. So we're going to go into it in more detail once we get there. Now, specific immunity, aka adaptive immunity. Cell-mediated, we talked about that as being involving T cells. So let me highlight what's important here. So T cells, that is cell-mediated, okay? B cells, that is going to be humoral, and it's going to be involving antibodies. That's going to be these guys over here. So let's move on here. So now, I'm going to show you a chart that's going to really kind of, hopefully, help you to distinguish between humoral versus cell-mediated immunity. So that's a chart. This is not from your textbook. This is from Nestor's Microbiology, which is a really good book for micro. But this is one of my favorite charts in there. Now, let's talk about how an antigen-presenting cell presents the antigens. Let's talk about it in terms of dendritic cells. Now, dendritic cells are going to be found in those like malts. They're going to be found in lots of different places. But just because we talked about malts during the last class, you guys remember what that is? Mucosal associated lymphoid tissues, right? And you find those in Peyer's patches. You find those in your GI tract. So what these little dudes do is they put out their little fingers into the environment and they scour the environment for dangerous antigens. Once they find a dangerous antigen, they take that antigen and then they present it to a T cell. So when they present it to a helper T cell, that's these guys right over here, the helper T cell is going to be first naive, but now it's been presented with an antigen. I'm going to write it as AG. That's how we write antigen in shorthand. Now that naive cell turns activated, and then it's going to deliver different cytokines. You don't need to know what cytokines specifically, but it's going to do one of two things. It's going to activate macrophages. Think of it as being like a hitman. Think about this T cell, the helper T cell. Think about it as somebody that's putting a hit on somebody, and it's hiring a hitman. The hitman that it hires is the macrophage. Now, the macrophage basically does the dirty work of the T cell. The macrophage is what's going to go off and kill the infected, whatever is creating the antigen. Okay? So we're going to talk about the next step with the helper T cell in a moment. Now, the other side of it is going to be the cytotoxic T cell. So actually, let me go ahead and do something here as well. So I'm going to do the other nomenclature, CD8, CD4. Make note of those, okay? Because we're going to talk about why that's important. Helper T cells, also referred to as CD4 cells. Cytotoxic T cells, also referred to as CD8, okay? That's cluster differentiation. I'm going to talk to you about what that means in a moment. So when a cytotoxic T cell gets activated, it becomes an activated cytotoxic T cell. It delivers a package, a death package, and it's going to be tumor necrosis factor alpha. You don't need to know exactly that, but if you ever hear tumor necrosis factor, you know that that's going to induce apoptosis. So if a cell is infected, this guy right here, it's now going to self-destruct through apoptosis. Okay? That's what the cytotoxic T cell does. It induces apoptosis in infected cells. It could be a virus in that cell, or it could be a tumor. It could be cancer. Think tumor necrosis factor. It could be a tumor. So it's going to basically induce apoptosis. So we talked about cytotoxic T cells. These are also referred to as CD8. Helper T cells, CD4. Okay? CD8 cells induce apoptosis, and CD4 are going to activate macrophages, but they're also going to activate B cells, which we're going to talk about on this next slide. So, we just talked about all this. The helper T cell helps to stimulate macrophages, but you can also get stimulation of naive B cells. Now, this is how the cell-mediated immune system starts to cross over into the humoral, because this over here is cell-mediated. This is going to be humoral, okay, on this side with B cells. Now, the B cell is activated. Now it undergoes proliferation and differentiation, becomes plasma cells, and those plasma cells secrete antibodies that are targeting a specific antigen. One antibody, one antigen. So that one antibody is not going to be good for anything else. It's only going to be able to target that one specific antigen. Okay? I hope that makes sense. I like this chart a lot because it simplifies what is otherwise a very complex pathway of adaptive immune system. So let's talk about the other annoying part about the adaptive immune system. It's going to be with antigen-presenting cells. So B cells don't need antigen-presenting cells because they have B cell receptors that are basically immunoglobulins just chilling on the outside of the cell, and they can directly respond to an antigen. Once they get presented, once an antigen is floating around, it will bind to the B cell, and it will help stimulate that whole differentiation, proliferation section of the humoral immune system. T cells, on the other hand, they have a T cell receptor, and that T cell receptor requires an antigen-presenting cell to present the antigen to the T cell. Okay? So that's the part that gets a little confusing and gets a little annoying. We're going to talk about major histocompatibility complexes in a second, but that's going to be part of different types of antigen-presenting cells. So, in other words, to summarize, T cells are not going to be able to recognize antigens that float around the environment by themselves. They need an antigen-presenting cell in order for them to get activated. Okay, so let's talk about that in a second here. So, major histocompatibility complex, or MHC. That's there's two different types. There's MHC class 1 and there's MHC class 2. We're going to talk about those in a second. MHC class 1, that's going to be found on all of our nucleated cells. MHC class 2 are going to be found on specific types of antigen-presenting cells, like dendritic cells, macrophages, and B cells. So those would be MHC class 2 on these guys right here. So what happens with antigen-presenting cells? What do? when a macrophage or a dendritic cell, like remember I talked to you about those dendrites, dendritic cells like picking up antigens, they're going to grab something from the environment, they're going to process it, and then they're going to take the little antigens, might also be epitopes. Epitopes are also antigens found on the outside of like bacteria, and they're going to bring it to the surface of the cell, and they're going to present that epitope or antigen, could be an, geez, that was terrible, A-G, scratch that. It could be an epitope or an antigen, and it's going to present that antigen to a T cell. Okay, so that's the MHC protein that holds the antigen to present it to the T cell. Now, let's talk about what cells have what type of major histocompatibility complexes. So MHC type 1 is going to be found on every nucleated cell in your body, except for RBCs. RBCs aren't nucleated. They don't have a nucleus. Okay, so they're not going to have MHC type 1. Now, MHC type 2, that's only going to be on antigen-presenting cells. Dendritic cells, macrophages, B cells as well. Now, MHC class 1, that's on all of your somatic cells in your body that are nucleated. It helps your T cells recognize self from other. Okay? So you have a foreign, so let's think about it this way. Let's think about a tissue transplant. Maybe you get like an organ donation from somebody. You get like a kidney or something. We're going to talk about HLA typing later on. It's a very side note, but this is a good way to conceptualize it. It's not exactly accurate, but it's a good way to conceptualize it. If you get a kidney from somebody, right, and get that implanted into your body, that kidney is going to have MHC1 from the other person. Your body's not going to recognize that MHC class 1 as its own. And so now you're going to have host versus graft rejection. So your body is going to basically destroy that kidney. Okay, so that kidney transplant is going to fail because you're not doing proper typing. It's a little bit more complex than that, but it's a good way to think about it. So that's what MHC class 1 does. It's found on every single cell in your body. It helps your T cells recognize, oh, that's one of me. That's one of my people. I'm not going to attack it. However, MHC class 1 can also be involved if the cell is infected with a virus or a tumor or a cancer type situation. And now it's going to tell the T cell, hey, I'm an infected cell, kill me. And that's what basically happens when MHC class 1 activates, for instance, a cytotoxic T cell. So the cytotoxic T cell gets activated, it's going to release tumor necrosis factor, and now it's going to kill the infected cell. So that's what MHC class 1 does. MHC class 2, a little bit different, antigen-presenting cells from dendritic cells, macrophages, and B cells. So here's another image. This is also not from your textbook. This is from Nestor's again, but it's a good breakdown of what cells have which MHC and which cells are going to be involved in that MHC recognition process. So for MHC class 1, that's all nucleated cells. Once the T cell gets activated, it's going to induce apoptosis or controlled cell death. Okay? And those are involving cytotoxic T cells, aka CD8 cells. The other side of it is going to be MHC2 on either B cells, macrophages, and dendritic cells. That's not included here. But those are going to have to activate helper T cells now to basically recruit macrophages and to stimulate B cells to undergo differentiation and proliferation. And that's going to involve CD4 helper cells. Those are T cell lymphocyte helper cells. So, to beat a dead horse, cytotoxic T cells, also referred to as TC, T little c, CD8, okay? Helper T cells, or just TH, those are going to be CD4. CD8, to further define what's going on, CD8, MHC class 1, CD4, MHC class 2. Okay, I don't really have a good way for you guys to remember that. It's like no good mnemonics that I can think of, but definitely commit that to memory. It's going to help you in this class for the next exam, and when you guys get into microbiology later on, it's also going to help you in microbiology too. So that's MHC class 1, CD8. That's going to be your cytotoxic T cell, okay? And then MHC class 2, that's going to be what it looks like. That's the actual MHC on the outside of the cell associated with CD4. That's going to be your T helper cells. Okay? And those would be the little antigens that's going to be presenting to those cells. And here's another image of what that looks like. These are CD4 cells. It's got the T cell receptor that receives the antigen from an MHC. Okay? And then that's your T cell helper cell. And it's cytotoxic T cells. That's your CD8. It's going to have CD8 receptor. That's why it's called a CD8 lymphocyte. So that's going to be cytotoxic. So just make sure you know which MHCs are associated with which.